Assalamu alaikum. Today I'm going to read AKP clinical case number 19, that is a collapsed 72-hour-old baby boy. A 72-hour-old baby boy born at term after an uneventful pregnancy and delivery presented with serious symptoms. Initially healthy, the baby became pale, tachypneic, and mottled, showing poor response to stimulation and difficulty waking. On examination, the baby was jaundiced with slow capillary refill, that is 4 seconds, poor muscle tone, and reduced reflexes. There were no signs of chest, heart, or abdominal abnormalities. His blood sugar level was slightly low, that is 3.1 millimole per liter, and blood gases showed partially compensated metabolic acidosis. The baby was transferred to the neonatal intensive care unit where he was intubated, ventilated, and started on intravenous antibiotics. Blood tests showed normal white blood cell count and CRP, suggesting the absence of significant infection. However, ammonia levels were critically high and bilirubin was also elevated. These findings point strongly towards a metabolic issue rather than infection or other common neonatal conditions. The first question asks for the most likely diagnosis among other options. Group B streptococcal septicemia is unlikely because the white blood cell count and CRP are normal, which is not consistent with significant infection. B. Hemorrhagic disease of the newborn. Hemorrhagic disease of the newborn is ruled out as there is no evidence of bleeding and the baby likely received prophylactic vitamin K. Next option is transient hyperammonia of the newborn. Transient hyperammonemia of the newborn is more common in preterm infants and causes higher ammonia levels, which do not match this term baby's case. Next option is hyperammonemia hyperinsulinism disorder. Hyperammonemia hyperinsulinism disorder typically present with severe hypoglycemia and mildly elevated ammonia, making it an unlikely cause here. So the correct answer is ornithine transcarbamylase deficiency, OTC. This is a urea cycle disorder because the baby has elevated ammonia levels of 950, severe enough to cause metabolic encephalopathy. This condition typically presents in male newborn after a couple of days of life. Elevated ammonia combines with jaundice, lethargy, hypotonia, and reduced reflexes strongly supports this diagnosis. The second question asks for the best management option to improve the baby's prognosis. The correct answer is hemodialysis, as it is the most effective way to rapidly lower ammonia levels in the blood. This is critical in preventing further brain damage and improving the baby's chance of survival. Other options are less effective in this situation. 10% dextrose infusion is helpful in providing calories and reducing protein breakdown, but cannot lower ammonia quickly enough in this emergency. An extended transfusion is not the standard of care for hyperammonemia and would not adequately reduce ammonia levels. Intramuscular vitamin K is irrelevant as the baby does not have a bleeding disorder. Total IV feeding is useful in the long term to reduce protein intake but would not immediately address the dangerously high ammonia levels. Here is the little explanation of urea cycle, also known as the ornithine cycle. That is the primary metabolic pathway by which the body eliminates excess nitrogen generated from the breakdown of dietary protein. It occurs predominantly in the liver and involves a series of enzymatic reactions that convert toxic ammonia into urea, which is excreted through the kidneys. The urea cycle consists of multiple enzymatic steps, each mediated by a specific enzyme. Defects in any of these enzymes can lead to a buildup of ammonia in the blood, a condition known as hyperammonemia. Urea cycle disorders are classified based on the specific enzyme affected. The key enzymes of the urea cycle include carbamyl phosphate synthetase 1, ornithine transcarbamylase, arginosuccinate synthetase, arginosuccinate lyase, and arginase. Among these, ornithine transcarbamylase deficiency is unique in that it is inherited in an X-linked manner, whereas all other urea cycle disorders are inherited in an autosomal recessive pattern. OTC deficiency, the most common urea cycle defect, results from a mutation in the OTC gene located on the X chromosome. This enzyme is responsible for catalyzing the reaction between carbamyl phosphate and ornithine to form sertraline, a crucial step in the urea cycle. When OTC is deficient or absent, carbamyl phosphate accumulates and is shunted into pyrimidine synthesis pathway, leading to an overproduction of orotic acid. This, coupled with the inability to properly process ammonia, causes hyperammonemia. Neonatal onset OTC deficiency typically presents within 24 to 72 hours of life when the baby begins feeding on protein, triggering ammonia buildup. Disorder primarily affects male infants due to its X-linked inheritance as they lack of second X chromosome to compensate for the defective gene. Females with OTC deficiency may exhibit milder symptoms due to variable X chromosome inactivation. In this case, the baby's presentation at 72 hours of age within severe hyperammonemia, hypotonia, poor feeding, and encephalopathy strongly suggests OTC deficiency. The absence of elevated inflammatory markers, normal coagulation profile, and lack of respiratory distress help to rule out other conditions such as neonatal sepsis, hemorrhagic disease of newborn, and transient hyperammonemia of the newborn. The timing of symptoms coinciding with the onset of protein metabolism after breastfeeding aligns with metabolic decompensation seen in OTC deficiency. Early recognition and management of OTC deficiency are crucial. Treatment focuses on rapidly reducing ammonia levels through interventions such as hemodialysis, while minimizing protein intake and providing calories via intravenous glucose to suppress catabolism. Long-term management may include dietary protein restriction, ammonia scavenging medications, and in severe cases, liver transplantation. This is all about from this case. If you have any question, comment below. Thank you for watching. Like, subscribe, and share.